etc. And I wanted to thank you, the registrars, for everything you've done over the last few months in helping deal with COVID-19. I want to also thank Jill Klein from the Melbourne Business School and the Melbourne Medical School, where she teaches some sort of cross-disciplinary subjects, and especially with the medical students, how to deal with stress. So thank you, Jill, for joining us today. And I'd like to thank the staff at the RACP too for making all of this possible. So I hope that you'll have the notes, which we sent out yesterday. I'm going to change the order slightly, but everything is still there. And I want to emphasise that what I'm going to say is personal opinion, and it's not official college policy at all. So my background is as a general physician and an examiner for nearly 18 years, and I have helped to organise the exam on multiple occasions. I'm not a member of the National Examining Panel, and I'm not a member of the exam committee, and I haven't been privy to any of their discussions. But I am someone who's played a role in trying to get our trainees ready for the exams for a long time. So these are my personal observations and the recommendations that are based on those observations, because I've seen a lot of registrars who've studied very hard and worked very hard, and sometimes the time that they put into the study isn't necessarily rewarded by an improvement in their presentations, etc. So I just wanted to give you some tips on how I think you can get better and how I think you can address the exam strategically and not get overstressed about it. I will emphasise that the official guidelines change subtly each year. Now, I have given this talk a few times over the past few years, and every time I give it, I add a bit more information. So it is kind of crammed with stuff. And a lot of it you can just read, and sometimes it's just to remind you to work on one area a little bit more. So be strategic. You are going to look back on this time as a time when you have learnt a lot of clinical medicine. I say be systematic in your preparation because you'll be more confident then if you're systematic. Concentrate on the important areas and address your weak areas. Ask last year's candidates for advice too. So this is how I'm going to go through things. I'm going to tell you the 10 things I think you need to do, 10 things you need to know, and some tips on the long case examination and on the short case examinations too. So the first thing I would say is get your long case template ready and perfect your prototype history and your examination template so that you know exactly what you're going to be asking when you go in to see your long case. And so that if you leave something out, you'll think, gosh, I've left something out. It was in that top right-hand corner. It should be so-and-so, and you'll remember what it is. So some of the things that are necessary to go on your template, and you'll all get your own, make your own templates, but who is the team who looks after this patient normally? And what's the interaction with the team like? Because that's going to give you a fair idea about the patient's care. But some of the other things that are important to include in the social history is whether the patient has a supportive family and friends, whether they have good pets and good neighbours, what things they like to do, what their finances are like, of course, how many steps they have, how accessible their house is at home, what services they receive currently, and then do they have a will, do they have a medical power of attorney, have they made some decisions about their end-of-life care. I've highlighted driving there because driving is always a nice topical area to be asked a question on in the presentation of the long case. So some issues in lifestyle history too. What is their nutrition like? Are they overweight? Do they smoke? Do they exercise? Do they adhere to their treatment? And we tend to use the word adherence rather than compliance now. I've put pets in a few times. Obviously, I think it's important. Immunisation, their cancer surveillance too. Some other questions that come up reasonably commonly are perioperative management. So if your patient has had surgery of some kind, if they're diabetic or if they're on anticoagulants, you may be asked, how would you have approached their perioperative management with the diabetes management and the anticoagulation? There are always some questions that when we can't think of anything else, we might ask, but they're good questions too because they're very relevant to your patient care. And then finally, some psychiatric history. Are there any features of depression here? Is there any issues with sleeping? And does the patient have insight about their illness? So once you've got your template done, and frankly, you could all work out your optimal template over about an hour this afternoon. From then on, whenever you're doing your ward admissions, use your template and just get used to it. And then every admission you do is really a practice long case. Secondly, in terms of your presentation for the long case, prepare a nice opening and use it every time that you do a presentation. A nice summary would be that this patient is a 54-year-old woman who's come from home where she lives on her own, and she's presented with increasing shortness of breath, probably due to progression of her interstitial lung disease. She also has the problems of so-and-so. So just something that you summarise everything about this patient that's going to be critical. And then of course you'll have a closing summary too, where you'll identify the major problems in this patient, and the examiners will compare your closing summary of major issues with what they think the major issues in the patient are, and hopefully they will be very similar. Personally, and I think I'm out on a limb on this, I think it's the quality of your practice long cases and not the quantity that's important. Often when I'm hearing long cases, and the policy in our hospital is to practice a large number, but often I find the registrars are really more concerned about their timing rather than learning from their long cases. I would put it to you that it's very important to learn from each long case you do, and work out what you did wrong and what you need to do better next time, rather than just trying to see a lot of long cases, because long cases take up time. The fourth thing I've put down here is prepare a typical complicated long case. So a pretty typical long case would be somebody with diabetes who's developed end-stage renal failure and then has a kidney transplant. They've probably got a few other issues too. And what I would do is to go through that long case and look up everything that's relevant to that patient's management. Find out if there's been a recent study that's looked at management. Consider the options for dialysis if the person has conservative management instead. Look up these studies and learn as much as you can, so that when it comes time to be quizzed on this, you can present those data. And if you do that with a practice long case, you will remember the answers that you gave and integrate them hopefully into your long cases in the exam too. So if you have a complicated practice long case and you also have a chance to get your phrases right, to put all those very complicated interacting features together so that you have a nice summary that sounds clear but that's got everything in it. This is going to help you with your timing too. Speedy screening examinations. About 30% of hospital inpatients with a medical problem have diabetes. So it's very likely you are going to have a person with diabetes in your long case, with whatever is their main issue. It may be just a comorbidity, but you need to have a very quick screening examination for diabetes, just like you would on the ward with all of your admissions. So you work out exactly what the complications are from this in this person, and you can do it quickly and you're not going to leave anything out. The same for CNS screening examination. You're not going to have time to do a full CNS examination unless of course it's a CNS case, but you need to be able to work out what is going on here and pick up some of the things that the patients may not have told you about. for example, they may not tell you that they have a peripheral neuropathy, but if they have renal failure, they may well have a peripheral neuropathy, or diabetes, they may have a peripheral neuropathy, but they may not tell you about it. So you need to have a screening examination for the CNS. Number 6, watch the practice long cases in specialised areas. So the State Committee in Victoria over the last 15 years or so has prepared practice long cases which are on the website, and these are all in the College Learning Series, either the 2018 and 2017 series, and we may be making some more presentations this year. So these are getting a registrar to prepare and present a long case, to be quizzed on it, and then a brief description of some of the issues from a consultant afterwards. These are all in areas that you may not be familiar with. For example, a cardiac transplant patient, or a patient with HIV, or a patient with a pancreas, a kidney transplant too. So these are to give you a little bit of insight into what it's like with these conditions. But of course, when you're examined, you will not be examined by an expert in that area. You will be examined by a person who's taking the role of a general physician. Timing in the long cases, this is a major issue I find with the registrars. What I would say to you is don't talk too fast. Just talk at a normal talking pace. The examiners will be watching out for you, and if you look like you're not going to, or if you're going to go over time, they might ask you to summarise your findings towards the end of the 12 minutes or so. They'll often give you another minute, maybe 2 minutes, to see how you go, because they know when they interrupt you and ask you to summarise your remaining findings, that it can be very disconcerting for you. But I would say to you, when you practice your long cases, practice your phrases so that you know if you use your template and give certain details, you're going to be on time. Short cases. What you can do now is you can get your short case examinations right. You don't even have to see patients to do this. You can look up your books, you can go back to your medical student notes, you can talk to your friends and to your study groups. So the short case examinations are basically cardiovascular, respiratory, abdominal, joint and CNS. And CNS, you won't get a whole CNS examination, but you might get gait or lower limbs, sometimes gait leading into lower limbs. Eyes, speech, cranial nerves. So uncommon to get upper limbs, but you can get that, of course. So what you should do is to prepare a list of shorts in each system, and you can do this over the next few months. And the likely questions that you're going to get, and find out the answers now. I'd also suggest for the short cases, probably the best thing you can do now is to take medical students or your interns for formal bedside tutorials on a weekly basis and go over these basic examinations. You are going to have to know them backwards. It doesn't matter if your examination is a little bit different from someone else's, but you have to be able to pick up all of the signs. And for those weekly tutorials, I would suggest that you look for patients on the wards and in your friends' wards who have good signs, and go over these features and these patients with the students on a weekly basis, because then you are starting in a serious way to get your study going. And I would start now, that is after you've revised and gotten your short case examinations so that you're pretty happy with where they are. Now I'm going to say, why am I recommending teaching medical students or interns? The reasons are, you need to know the medical student examination basics really well. And I do know that when I've seen registrars start out saying I'm seeing, I'm seeing shorts already with people from my study group, what happens is that the weekly sessions often fall over. And they'll say, oh, look, we started to do it, but by week 3, I was really busy on the ward, and my friend was on nights, and so it just didn't happen after that. What I will say is if you have medical students that you're giving tutes to, you're less likely to cancel. Whereas with a friend, you cancel. So that's the reason I've recommended medical students. If you don't have medical students on the ward, then do it with your interns. In addition, the medical students don't threaten you. You can of course do it with your colleagues too, but it's just that doing it consistently with medical students is a good way to go. Medical students don't threaten you because they're unlikely to know more than you do, so that you're always going to feel that you're learning and being pretty confident. They will tell you if other consultants do things differently, like they might say, well, the respiratory consultants don't do it that way anymore, or they don't do it that way. Or my favourite is when someone said to me, Professor Berkovic doesn't test for ankle jerks that way. So then, of course, you sit up and you think, well, if he doesn't do it that way, maybe I need to just modify that. You will see a lot of interesting patients starting right now. And the medical students will ask you questions out of left field. And that's actually what happens in the exam. And you're going to learn how to answer those questions. You're not going to say to the medical student, I don't have any idea why that's so. You're going to try to go back to basics and to give them an answer that's accurate and correct, even if it isn't exactly what they wanted. But you will, I think, go away and remember that you didn't know that and maybe look it up. And the medical students will give you lots of positive feedback, and the interns will too. They'll really appreciate you doing it, and it will help you get through this period of time. So onto the clinical examination, and this is from a description of the exam from a little while ago, but I think it's still true. It's designed to test clinical skills, attitudes, and interpersonal relationships. And the clinical skills include history taking, physical examination, the interpretation of findings, the construction of a diagnosis or differential diagnosis, method of investigations, and general management of the patients. So I now want to head into 10 things you need to know for the clinical exam. So this exam is really about testing clinical skills, and it's not about facts. You've had the written exam, which was very much about how much you knew. This is a different exam. And the emphasis is on patient management in the long case and detecting physical signs in the short case. The examiners don't examine in their specialty. And often when they ask you, what could this be due to? You might give one answer only, which is maybe the correct answer, but they'll often ask, what do you think, what are the likely causes of this? They mean in this patient. They don't mean in general. So I've said here, forget about leishmaniasis, which I've heard candidates say twice as a cause of splenomegaly. It's unlikely to be a cause in this country. So the examiners want often the three most likely causes in this patient here today. So you're taking into account the gender, the age of the person, whether they look all right overall, etc. Your textbooks often have very long lists of causes, and you need to even now work out the list in your patients, the three common causes of some of these common manifestations. For example, the three commonest causes of clubbing in the patients you see. Now, continuing, the standard required for the examination is that the candidate is ready to begin advanced training and performs at the level expected. You need to know that there's a finite number of short cases. It's not infinite. And you can prepare for these, and you should know what the common cases are, and you should prepare for them. You should expect the unexpected. There are many, many examination sites, and they may do things slightly differently. And the other reason for unexpected occurrences is that often there are crises on the examination day. And I think that the best one I heard was that one of our patients was going to be for the exam. He rode his bike to the exam and he rode to the wrong hospital. So he wasn't an examination patient for us, and we had to find another patient very quickly. And we always have some reserves. Often they come from the ward, and so you may get acute patients too. Now, everyone understands how stressful the examinations are and the preparation also. And when I say everyone, that includes the examiners. The pass rate isn't capped. It's not as though only 2/3 will get through the exam. Theoretically, all of the candidates can pass the exam. So you're not in competition with other people that you may be studying with. The more you can help each other, the more you will enjoy the preparation and the more you'll learn. You don't have to know everything or get everything right to pass. And often, if a candidate is doing very well, they will be asked more and more complicated questions. So don't get disillusioned if you can't answer all of the questions. It may just be that the examiners are trying to work out how high a mark they give you. The examiners also recognise that there are different ways to do things. And this doesn't matter if your technique is slightly different from other people's, as long as you get the right answers in general. I must say that the examiners do like you to look as though you have done this examination many, many times before. Most people fail at least one short, and I think this is still true. You can still fail 2 shorts and still pass the exam if you do well in the long cases. So it is worthwhile preparing the long cases very well. But most people do pass the written and pass the clinical examination. In the overall scheme of things, it doesn't matter if you fail the exam the first time. You may be very sensitive about it, but the consultants often won't remember that you passed. We all know that no matter how fair the college tries to make the exam, that sometimes people who should pass don't pass. And we all know some very well-known and very good clinicians who haven't passed the exam too. The examiners shouldn't indicate to you how you've performed. So sometimes when I ask the candidates after the exam how they think they went, they say, look, I can't say. I thought I did all right, but the examiners just wouldn't look me in the eye when I left the room. Well, that doesn't mean anything. The examiners try very hard not to look sorry for you if you haven't done well, and they try very hard also not to say well done, congratulations or something. They won't say that, but they try not to indicate to you how you've performed, because we all know that you can fail the shorts and still pass the exam overall, and they don't want to make you disconcerted about how you think you might have gone, so that you don't perform as well as you might in the next cases. So this is something I've usually included, but it's a little bit different in this year. So I've said there isn't usually much time after the exam before you have to organise an advanced training position. But this year you're going to be studying and trying for a training position all at the same time too. So the exam organisation, the patients are often very experienced and are recruited months in advance. So often the signs they have are pretty fixed. The patients are usually able to give a very good history. They know their disease very well too. And the coordinating registrar at each hospital will hopefully put together groupings of long and short cases. They know with each candidate they get which long and short cases they will have, and so they try not to get too much overlap. So if you have a neurological long case, then you certainly won't get 2 neuro shorts. However, having said that, expect the unexpected. Sometimes reserves are brought in from the wards if one of the patients doesn't turn up, or if there's other, or if they're very sick, etc. So with a long case, typically they give a very good history. They usually have a complicated history, and they have at least one physical sign. I have seen a long case with no physical sign. It's unusual, but it happens. And typically they'll have a chronic disease that has some kind of little hiccup or crisis. So it might be their disease is progressive, or they have a complication of the disease or of the treatment, or they have a second coincidental disease. And they usually have many comorbidities and they're on lots of medications. Sometimes there is no issue, and sometimes the issue is not medical. So sometimes it will be that for example, I've written here, their major concern is that they're increasingly frail, they're unable to look after themselves at home, and they're wondering they'll need to go into somewhere where they can be looked after, and they're wondering who will look after their dog. If that is their major issue, that's their major issue, and you should bring that up in the presentation as what the patient is most concerned about, because sometimes the answer is relatively easy to put the patient's mind at rest. So the skill with a long case is to tie everything in together and to tell a story about this individual. I've put in a few examples of long cases, and I've actually, because I'm a renal physician, as well as a general physician, I've emphasised the renal cases a bit. There's quite a few renal cases, long and shorts. They're not always done very well. So this is just to give you an example of how complex they can be. Vagus granulomatosis and lung disease, lupus, kidney failure, transplant, chronic liver disease, IgA glomerulonephritis, non-Hodgkin's lymphoma, nephrotic syndrome, HIV and FSGS, etc. So long cases, we don't get a lot of oncology in the long cases as the primary diagnosis, partly because often the clinical features are changing and the circumstances are changing. Sometimes the patients don't want to discuss their illness, especially if they're undergoing treatment currently. But we certainly get a lot of patients who have a past history of CA of the breast, lung, colon, prostate as comorbidities. So you do need to know some of these common cancers and what the complications of therapy can be. And I've mentioned before, there's the special long cases with transplants, and they're in the college learning series. So common comorbidities, you need to know these backwards. Diabetes, hypertension, atrial fibrillation, dyslipidemia, osteoporosis, obesity, OSA, etc. So you need to know about these, because often this will be considered the area that your second examiner will ask you about. They may ask you about the interaction with the major issue in the patient. They may ask what the contribution has been from some of these comorbidities, or how the person's lifestyle is affected by their comorbidities too. So you do need to have a very good understanding of these and the treatments too. So some common complications and of medication, in particular the steroid side effects, immunosuppression and the risks, and as I mentioned before, diabetes and perioperative management, especially the perioperative management, is a common question. So what's the expected standard required? This will be that you identify all of the key problems in the patient and that you arrange the problems in the order of priority from most significant to less significant. So in the history, what is the patient's major concern? And you ask them what their major issue is, and the examiners will ask them too. How has this illness impacted on their life? What does the future hold for them, to get some kind of understanding of how much insight they have? And then it's very acceptable to say, is there anything else I should know? And the patients may say, well, you haven't asked me about my gout, but that's not really much of an issue at the moment. Or they may tell you something else, but it's absolutely okay to ask them, is there anything else I should know? So in presenting the long case, one of the examiners will lead, and they'll ask you, first of all, if you had any problems seeing your patient. Then you will, that will be your lead examiner, and you will address that examiner principally, because they will ask you questions for about the next 20 minutes. And the other examiner will question you for the last 5 minutes, and they will usually change tack completely. There may be a third examiner in the room. That person is the observer, but in the afternoon, the observer may ask you questions too. So you will present your patient for 11 to 12 minutes out of the 25. And we've talked a little bit about a good introduction, which will be pitched at the consultant level. It needs to show perspective, and you need to understand the impact of the disease on the patient, and you finish with a summary and the list of issues. So this was just an example from one of my registrars years ago. He's now a professor of cardiology. So just getting the words right. In summary, Mrs. X has a chronic disabling rheumatoid arthritis and ischemic heart disease and 5 major management issues. And you'll find that most of the candidates will address, say, 5 management issues. But you can see the last ones are addressing her significant polypharmacy and providing her with greater community links and resources. So they're not really medical issues, but they do impact on her illness. So the questions on the long case typically are clarification of points of history or examination findings, like if the examiners didn't catch that you mentioned the blood pressure, they might ask you what her blood pressure was. Maybe you forgot to mention it. What's the biggest problem for this patient? How active is the disease currently? It's about linking the different clinical features. There may be opportunities to optimise treatment and the management. How does the illness impact the patient's life? And then I keep on mentioning perioperative management for a reason. Common reasons for failing the long case: if you miss something, you don't have perspective, poor social history, and if you get wrong what's important to the patient, have no comment on the prognosis and no discussion of the management issues or the wrong management issues. So with the long case, this is where I said it's good to have some screening examinations that can be quite quick. For your diabetes, this will probably be a comorbidity in your patient, but it may not be. But you still need to go through and see what kinds of complications does this person have from their diabetes. And of course, a lot of people, if they've had diabetes for 10 years, will start to have complications, type 2 diabetes. So you might work out a list of things like this for yourself, and I've just included some ideas there. And again, a CNS screening examination, and I've just included some ideas here for how you might develop a quick screening examination for your patient. Screening examination where there's no history of neurological disease and you're not suspecting a neurological disease, but you want to make sure there aren't some features there that the patient has neglected to tell you. Because of course patients don't know a lot about the signs they have, and a lot of the neurology they won't know, they won't have symptoms from. So I've just gone through again, this is CNS and the cranial nerves and some of the things that I look for. You get a lot of information from the quality of the talking, whether the person has cerebellar disease, whether they have some dysarthria. You might have abnormal speech with Parkinson's disease too. You might be able to tell that the person has an old stroke. So you'll get some information from that. And then there's some other things too, facial asymmetry, nystagmus, and I find looking at the uvula and tongue pointing and making sure they're midline are good for checking bulbar function. And then in the limbs, you'll find neurologists often just get the patient to play the piano. I look for increased tone with unrolling the fingers, looking for Parkinson's, biceps reflex and finger nose test to a fixed point will pick up cerebellar signs. And then some signs, some tests in the lower limbs too. So all of this is quick CNS screening examination. It might take 2 minutes at the most, but you've got a lot of information. With renal failure and the long case, I find that the registrars often do not have a very good history of renal failure, aren't able to take a good history of renal failure. So I've put some ideas down here of some questions to ask about, like who manages you, what complications do you have, what dietary restrictions are you on, do you have to take your caltrate tablets when you have lunch or breakfast, what kind of treatment are you going to opt for? Are you going to use what kind of dialysis, hemodialysis, home hemodialysis, etc.? Who's going to help you with it if it's at home? You want some idea about adherence, and has the issue of a transplant been brought up? With renal failure, again, the examinations often, people leave things out, but there's a lot of things that you can look for in a renal patient with renal failure. Again, if they're not there, you can mention that they're not there also. A dialysis patient, again, there's some things that you need to know about it. It might be worthwhile getting a tute with one of your renal registrars to talk a little bit about what are important, what are the features that are important in the management of a dialysis patient. So you'd want to know if the patient's had any problems with their fistula. They might say, this is my third fistula. You want to know what their base weight is when they come in for dialysis. What do they normally weigh? Are they normally 3 kilos overweight, which is going to cause some problems on dialysis. You want to know what their urine output is, because that will mean they can drink more fluid. A whole lot of other issues there too. Can they go on holidays? Have they ever been on a holiday where they've been to a dialysis centre? Are they a member of a patient support group? Have they had any achievements on dialysis? For example, did they manage to finish their university degree on dialysis, or they're still working on dialysis? And again, their prospect of a transplant. And a transplant history, likewise, you can go through and talk about how long they're on dialysis and any complications, who they got the transplant from, did they have any problems around the surgery there, and any complications of their immunosuppression after treatment. Has their original disease recurred? It depends on what the disease is, of course, but some do recur. If their fistula is still working, and is this their first transplant or second? And again, any achievements, things they can be proud of when after they've had their transplant. And likewise, in a transplant patient, the kinds of things you can look for, and you can make your own list here. So just finally, I want to go on to the short case and talk a little bit about the approaches there. And there's really 5 systems that you can get. Having said that, you expect the unexpected, but optimally you will get 1 cardiac and 1 neurological short. And you'll get 2 from the group of abdomen, respiratory or joint examinations. So preferably you won't get 2 patients with the same system, but you can do sometimes. And coordinators try to avoid spot diagnoses, so they do try to avoid acromegaly. Things like that. On the other hand, you might get acromegaly as part of a long case examination. So with the short case, you have 15 minutes in total, and you have 7 minutes for the examination, and the examiners will be timing you, and then they will ask you, is there anything else you want to do? Would you like to tell us about your patient? And you'll do your presentation, and then in the discussion, the kinds of questions they might ask would be about the severity of what you found, the activity, whether it's active or inactive, what the likely cause is, what else it could be, and why you are opting for one of those causes. They might also ask, are there any complications from this? Would you like to look for them, etc. So you do usually get asked about differential diagnoses, and the final part of this short case might be, what definitive investigation would you like? So I don't like asking about investigations, but every time when I examine with the National Examining Panel, they almost always ask for an investigation. I don't like the investigations because you're showing them something. It takes the candidate a little while to work out which is the top of the result sheet and which is the bottom, because the formats are all different. And often it will just confirm what they've already said, the diagnosis. So there's not the opportunity to get a higher mark. So questions for the short case are typically, what have you found? What do you think is the most likely diagnosis? What else could it be? And why do you think it's not that? What other complications does the patient have of this condition? They may say, have a look and see if you can find any other complications. Which tests would you perform to confirm this diagnosis? And well, here's the echo. Would you like to look at it and tell us what you think? So the pass standard for the short case is that and this is actually from one of the former director of physician education at the Alfred, and she has said it's that the candidate performs the clinical examination efficiently and confidently, detects the signs accurately, interprets the signs, assesses activity, etc., identifies possible causes, formulates differential diagnoses, names relevant investigations, and interprets the investigations accurately. So that sounds a lot to pass, but it's usually pretty straightforward. So the short case, you do have to show perspective in your answers. As I said, leave out the leishmaniasis, and often the examiners will ask for the 3 most common causes. So I'm going to say to you now, you need to know the clinical features of all of the cardiac valve abnormalities, not just valve abnormalities because they're getting less common, but HOCM and also cardiomyopathy. And you need to know how to assess severity, and you need to know the indications for surgery for the valves. So you need to know what echo findings you expect, what gradients you expect, etc. You need to do that. You need to just get some, if you use flashcards, get some cards and start doing that now. Check that if whichever textbook you're using, that they're still the current criteria, because I find trainees, even the week before the exam, don't know the criteria for surgery, and they say, don't worry, I'm going to revise it all the night before the exam. If you revise it the night before the exam, you'll probably remember it for 2 days, but you may not remember it for the next 30 years. So common short cases, and I said before, the short cases, there's a finite number, and you can prepare for your short cases. And this may look like a long list, but it's actually not that long. So I would encourage you, do a little bit of work now before your tutorials are ramping up. And again, if you use system cards, whatever you do, probably use your phone, make your lists of these conditions and what you expect, and go through the kinds of questions that I've described. So cardiovascular shorts, I've said, get your examination perfect now, know how to assess the JVP and the pulses, the different kinds of pulses, know how to work out where an apex beat is, work out which manoeuvres you're going to use. I usually use 4 manoeuvres. You may use a 5th, but these are the ones I use. Listen to the murmur in inspiration and expiration, do a Valsalva, lower left sternal edge leaning forward in expiration for aortic regurg, and left lateral position. So work out what you are going to use. In the cardiac examination, feel for pulsatile liver, which you'll need if it's tricuspid regurg. Know how to assess the severity of the valve lesion clinically and the likely cause, and the echo criteria for surgery for each valve lesion. Respiratory short cases, there's really only a few, and these might be diffuse interstitial lung disease, bronchiectasis, pleural effusion, lung resection. Crepitations are pretty common, and you need to know what are the differential diagnoses of crepitations. A common question might be, when you've said that there are crepitations here, why do you think it's diffuse interstitial lung disease and not pneumonia or heart failure, which you suggested it could be also? So usually with heart failure, people are very short of breath if they have creps in the lower third of their lungs, whereas with diffuse interstitial lung disease, they're not short of breath. So with interstitial lung disease, a very common short case, you need to describe the crepitations in detail. You need to say if they're end inspiratory, do they clear with coughing, where are they in the lungs, so how far up the chest wall they went, if they went 1/3 of the way up, if they went half the way up, if you could hear them in the axilla, if they were different in the right and the left, if there's any features of pulmonary hypertension. And then if you can, see if you can work out why this person has interstitial lung disease. So it could be that they have rheumatoid arthritis, and they might have had methotrexate therapy. They might have atrial fibrillation and have been on amiodarone. They might have psoriasis or psoriatic arthritis and have interstitial lung disease from that. So have a bit of a list for causes, and so once you've finished your chest examination and listening for pulmonary hypertension, you might go and start to look for the causes in that patient. Abdominal short case. This is my favourite STEM, which is that a person presents with tiredness, and then please examine her abdomen. I like this as a STEM because it doesn't tell you which system is affected. So it could be liver, it could be kidney, it could be hematological. And I'd say this is the approach that I have taught our registrars. If you're asked to examine the abdomen, then start with the abdomen, take a few deep breaths, look around and look at the patient, look at the left forearm in particular, because that's where the fistula usually is. And if the patient's got a long sleeve gown on, I'd be looking under the long sleeve gown. Get the patient to take a few big breaths, because sometimes you will see the outline of a polycystic kidney or a spleen with a few big breaths, and especially with a cough, or if there's any hernia there too. Just a few points: percuss and measure the liver span in the midclavicular line. It's much more common to get a toesed liver than an enlarged liver. Palpate for the spleen under the rib cage, and then roll the patient towards you and percuss, seeing if there's any way you can feel an enlarged spleen. Work out now how you're going to test for ascites. Often you'll see some loin fullness, and so you'll think that's suspicious of ascites, but make it so that it's all in the nice one manoeuvre. And usually I percuss towards myself and then keep my finger where it's dull in the flanks and get the patient to roll the other way, and then see if that becomes resonant. And one thing I would suggest to you is, after you've done the abdominal examination, progress to the relevant system. So it'll be usually liver, chronic liver disease, hematological examination, or to a renal examination. Often we find after the abdominal examination that the candidate will go and do a cardiac examination and a respiratory examination when we say, is there anything else you'd like to do? That won't actually get you extra points. So better if you can work out which system you think's affected, and then have a look and see if there's any features there that might go with chronic liver disease, etc. So the abdominal short case, usually it's going to be polycystic kidneys. You might have a liver too, you might have a transplant, could have splenomegaly, could have hepatosplenomegaly. Unusual to get hepatomegaly. And the causes are going to be polycystic kidneys, possibly with renal failure, chronic liver disease with portal hypertension, or a hematological disease. And a lot of the spleens that we have are due to polycythemia rubra vera or essential thrombocythemia. So polycystic kidney is a pretty common short case, and the kidneys may be asymmetrical. So it may not be a very, not polycystic kidneys like how you think, with two enlarged kidneys, but you might have one big kidney and the other kidney isn't palpable. As I said, you can also get polycystic liver there, and you can get a renal transplant, and you may get polycystic kidneys with splenomegaly from another cause. So usually you cannot palpate a cystic spleen from, if it's there from polycystic kidneys. Just with liver enlargement or a toes liver, measure the span in the midclavicular line, as I said before, but also feel the surface of the liver, the surface and the edge and the consistency, and describe those when you present the findings. Make a comment on whether the liver is tender, whether it's pulsatile, and I like listening for a bruit. It's part of the examination, and you will pick up a hepatocellular carcinoma. If there's a bruit, about 50% of them have a hepatocellular carcinoma, have a bruit. So it's a nice sign clinically. So I've put in quite a few lists here: causes of persistent hepatomegaly, causes of persistent hepatosplenomegaly, causes of splenomegaly. And again, this is where teaching the medical students comes in handy, because you will be asked, what are the features that make you think that this is splenomegaly? So you need to have all of those features, and there's sometimes 5 and there's sometimes 6 in the list. You need to have all of those features at your fingertips. When you have a person with splenomegaly, you want to try to work out whether you think this is a liver disease or a hematological problem. And if you think it's due to liver disease, then in your general examination, you want to be looking for features of chronic liver disease, features of portal hypertension, features suggesting alcohol use, abuse, and features suggesting decompensation. And you may very well be asked, what features does this person have of chronic liver disease? What features do they have of portal hypertension? What features do they, is there any explanation for the chronic liver disease? And what features do they have that suggest decompensation? And typically you would be asked all of those questions in succession. So characteristics, I've said, of splenomegaly with the features, and these are the medical student features, but they're good in clinical practice. And causes of persistent splenomegaly, they're really portal hypertension, myeloproliferative conditions, and lymphoproliferative conditions. Polycythemia rubra vera and essential thrombocythemia are much more common than myelofibrosis and CML, and but the spleen is often tiny. It's just like a little fist underneath the left costal margin. So if you do think that the person has a hematological condition, go on and do a hematological examination, a systemic hematological examination, rather than doing the heart and the respiratory examination. Rheumatological short cases, usually you'll get hands or knees. Sometimes you might be asked about the back with ankylosing spondylitis or shoulder, but that's less common. The rheumatological hand short case, it's not just rheumatoid arthritis. I've seen 4 candidates all fail when they had a hand with gout that had a lot of the features of rheumatoid arthritis, but it was due to gout only. So you need to recognise that a lot of rheumatological conditions affect the hands, and any of these conditions might produce a hand short case. What about when things go wrong in the short case? Well, you won't necessarily know, and just remember, it's unlikely you'll pass every short case. And don't get too upset, just think that was the one I was meant to fail. And you can, at the moment, now, by preparing well on the long case, you can make sure you get extra marks on the long case. And make sure you do really well on the long case. And remember, this is my final slide, the examinations and the preparation are all undertaken by your consultants in an honorary capacity. And so next year is going to be your turn. When you're asked to, if you've got any good cases or if you can help out with organising the exam, please say yes. Thank you.
Thank you, Judy. We have 3 questions. The first one is from William, and his question is there any update on the format of the clinical exam and when it will be conducted?
I wish I knew. As I said, this is an unofficial presentation, and it's really come out of Victoria because we thought it would be good to do something for the trainees. No, I don't know. The committee, I think, has not decided yet. Judy, and I will find out when the rest of the college finds out.
And if I may, I will, in the chat box, I will put in the link to where you can access all the most recent updated information from the college on the exams.
Right, thank you. Good.
The next question is also from Will. What other resources would you recommend for clinical exam? Example, books, online resources, videos, etc.?
The books change every year and the resources change every year. I don't keep up with it, but the senior medical registrar and the people helping you prepare for the exam in your hospital will know what's good. What I would say though is keep things in perspective. So you may have a list of 22 causes of clubbing, but a lot of those causes are not going to be common, and always in the exam, it's not about factual information, and it's about what do you think the cause could be in this person. So there's no point in saying something that's highly unlikely to be relevant. I think if you speak to the registrars from last year, they'll have some ideas about what's good. And I know that there's some good sites on the internet, for example, gait and neurological features too. But this is not about you being a neurologist. It's about you having a good systematic examination and being able to pick up clinical signs that will help you with the diagnosis. And one more question.
Any tips on what to do if the examiners get fixated on that bit of info you failed to extract in your long case?
The examiners will try very hard not to do that. So you can just say, look, I'm sorry, but I didn't ask that. It's part of my normal examination, but I didn't ask and I don't know the answer to it, and they will move on. There's the person from the National Examining Panel is very, very experienced, and if you cannot answer a question like that, it's just a waste of time to spend time on it, because you could demonstrate how much you know in other areas. So just apologise and say that you can't answer the question.
Thank you, Judy. There are a couple more questions. Would you like to proceed?
Is that okay with Jill if I answer a couple more questions?
Sure, go right ahead.
Good, thanks.
Short cases, do you recommend verbalizing examination findings as you go or save them towards the end?
Yep. I used to say that for the rheumatological examination, to describe what you find as you go, because there's a lot of changes to find in the hand and you may miss out something if you wait till the end. But I notice now that a lot of the trainees actually just present it at the end, and they may just look back briefly to the hand to think, oh gosh, you know, what else did they have there, when they're doing the presentation. So it doesn't matter what you do. It's just like the examination. As long as you get the major points, get the diagnosis, you're going to pass. I think for things like the cardiac and abdominal examination, even respiratory, usually you do not talk while you're doing the exam. You just summarise at the end with what you found, and rather than talking through the examination. But the hands would be one examination where you may also do it for neuro, but see what you're comfortable with. But there's been a tendency in the last few years not to talk until the end.
Judy, there are a couple of questions about the webinar being recorded. Yes, the webinar will be recorded. I've also put in the link where the recording will be saved in the chat box, and we'll also send you a link next week of the recording. There is one more question, Judy. What are your thoughts regarding stepping up as PAT with preparing for the clinical exams? I think that's provisional AT, provisional advanced training.
Yes. I don't know. If you can get into an advanced training position and it's the area that you want to be in, I would take that position. Yeah. I think the college, as I understand it, has asked heads of units to be supportive of appointing people who may not have gotten their clinical exam to the advanced training positions. But if you have the offer of an advanced training position, but you haven't got your exam yet, I would take it.
There are no more questions.
Okay, thank you everyone. As I said, this is the talk that I have put together over the years, so there is a bit of repetition, but the kinds of lists that I've drawn up, they're not perfect, but you can build on them to get some ideas about how to approach the long and short cases. Thanks. Thank you.
Okay, shall I just jump in?
Yeah.
Okay. I'm going to go ahead and share my screen here for you. So hi, everybody. So I'm a professor at the business school and at the medical school. By training, I'm a social psychologist. Got my PhD back in 1990 from University of Michigan. And I do work around resilience and well-being. I work on the well-being curriculum for Melbourne Medical School, and also do work on diagnostic error and biases, cognitive biases in judgment. Okay, so let me go ahead and share my screen. Let's see, here we are, boop. Okay, and let me start here. Okay, so I'm going to talk a little bit about something called growth versus fixed mindset. And what I'd like you to do first is to just have a look at these two statements and think about which you tend to agree with the most. You can learn new things, but you can't really change your basic level of intelligence, or you can change even your basic intelligence level considerably. So just think for a moment, in general, which one do you tend to agree with more? Okay, so just hold on to that for a moment. Now, we could have all kinds of discussions about what do scientists say is the right answer to that question. And I can tell you that basically the science is in between the two, moving towards the right more and more with each year as we learn how plastic the brain is and how the brain changes even as we're adults and as we learn things. But what's the most relevant here is what we believe. So it turns out, you know, research shows, and it's summarized very nicely in this book, that when we believe that intelligence and ability is fixed or static, that leads us to handle things differently than when we believe that intelligence or talent can be developed. And this can play out in specific situations too. So for example, if you sort of think, well, in terms of these exams, you know, some people, they've got it, they just, you know, naturally know this stuff. They're naturally good at this stuff. And some people don't have it and have to struggle much more. So that would be sort of this fixed mindset view. And what ends up happening when people think you either have it or you don't is you can often avoid challenges or give up easily. And I'll give you an example. I teach this to the Australia Institute of Sports coaches. So these are the coaches for the Australian Olympic teams. And when I was teaching them about growth versus fixed mindset, they were saying, oh my gosh, we see this all the time because they bring teenagers. So if you're 15 years old and you get to go train with these coaches at the Australia Institute of Sport in Canberra, which is like the Porsche or the Ferrari of training facilities. It's absolutely fantastic. And if you get to go there as a 15-year-old, you've probably been the best kid on the basketball court or the, you know, fastest kid on the track, and, you know, no one's probably ever beaten you. And then you take all of these kids and you put them together for these development programs in Canberra, and half of them are on the weakest half of the group for the first time in their whole lives, and they really have trouble with that. And what the coaches tell me is that they always find a couple of young people who at the end of the first week come up with some reason for why they have to go back home. And so that's of course a shame for them, because you know, they are just finding it so confronting. They have been told all their lives that they're brilliant, that they're a natural, that they're amazing. And that's become a huge core part of their identity. And then when they're confronted with not being the best, what they do is they kind of look to go back to where the setting fits their identity. They're going to go back to that track or that swimming pool or that court where they are the best. And so you often see this. Now, for all of you, you probably had a similar experience when you started medical school. And this is actually something I talk to the medical students about, which is that, you know, they're mostly selected because they've been top of class, and then we put them all in together and we grade them on a curve. We're not at Melbourne Medical School grading first year students now, but I think they're still keeping track of how they're doing relative to each other. So if you remember that, you know, your first year in medical school, and most of you were probably used to being top of your class, you may have come in with a fixed mindset because many of you got a lot of experience of being praised for being so smart, so intelligent, such a natural at scholarly endeavors. And that was a core part of your identity. And then you come in and except for one of you, you're going to be not the top of your class anymore. And when I have talked to third and fourth year students and I asked them, so, you know, how did you deal with that? How did you cope with that? You were used to being top of the class and then you had to learn something different. And they said, yeah, you know, look, we had to recalibrate. We had to wrap our identity around something new, like being in the class, being part of the class, part of a great class of medical students, but had to recalibrate the identity away from being top of class. But a lot of them told me that it took them months to do that. And it through painful processes of, you know, getting mediocre, meaning average for this amazing group, test scores, and then, you know, having to recalibrate their identity. And that was a long and painful process during a very, very intense and busy year. I used to teach this and talk to students about this on their last day of medical school to get them ready for internship. But after the first time I did that, I had 4 students come up to me in tears and say, where were you 4 years ago when we started medical school? So now we do that at the second day of medical school to help people get recalibrated more quickly. But yeah, so a lot of research tells us that when we have this kind of fixed view of abilities, we may think that it should be easy. And if it's not, then I don't want to, you know, be doing this. We can often be very defensive when there's negative feedback because it's a threat to our sense of selves. If you feel like you either have it or you don't, and you think you do have it, then anything that suggests you might not have it could be very threatening to you. And so you often see people pushing back against negative feedback. And a lot of you are already supervising medical students and interns and so forth. And you may see some of this defensiveness in some. And it may come from the fact that they have this fixed mindset. When people have this more growth mindset view that you get good at things through experience, through practice, through sometimes having setbacks and learning from those setbacks, from learning from positive and negative feedback, then people's approach to difficulties is very different. If you have a major setback, you're not out popping the champagne and saying, oh, that was a great life experience. You know, you might still be upset or disappointed, but your take home from it is very different. It's okay, this is part of the process of getting good at something, and setbacks are normal. And so that's sort of the whole growth versus fixed mindset idea, and it's got 40, 50 years of research behind it. And a lot of this research has been done on children and teenagers, but there's also been work on adults as well, and it shows very consistent findings. But I want to tell you about one study because I think it's very relevant to the kinds of exams that you're going to be taking. So in this experiment, what we had were executives. So these were executives who had come for training, and they do a simulation. So it's a computer-based simulation where they're told you are the head of a furniture manufacturing company, and you're going to have to make decisions along the way, and you'll get feedback on each of your decisions in that you'll make a decision for the company, and then you'll see how much money the company is making. And so that'll kind of give you an idea of, did you make the right decision? And you'll get to make 12 decisions, and after each decision, you'll get feedback. So that's the setup for this simulation. And then they're told, either half of them are told this is a learning exercise, but half of them are told this is a test of your managerial ability. And so what happens is that the simulation is designed to be really tough in the first few rounds. Most people make the wrong decisions and the business suffers, but people learn from those decisions and then tend to get better and better. And so what they found in this research is that people who had the growth mindset orientation, so this is a learning exercise, they're the blue lines, and they tended to get better and better with experience. You can see that one blue line person kind of tanked, but not too horribly. But when you see people really falling off the curve, really having difficulty, kind of falling apart in this simulation exercise, it's mostly the fixed mindset people. And I should mention this research was done in two ways. One is the way that I described for you, where you just gave people a fixed versus growth mindset framing for the activity, for the exercise. And you see these effects, but you get very similar results if you just measure the mindset they come in with. And so a fixed versus a growth mindset can be something that we kind of chronically carry around with us. It's the way we see the world, but it can also come from the way a task is presented to us. And so one thing you can be thinking for yourself is, you know, in my learning and in my preparation for this test, and as I imagine myself taking this test, do I have a fixed mindset view or a growth mindset view? Is this examination, this clinical examination, is it part of the process of becoming a good doctor? Or is it something that's going to prove whether I am a good doctor or not? Is it going to show whether I'm worthy to be in this profession? Do I have what it takes? And if we're framing it more in that fixed mindset view, we may be more vulnerable to falling apart a bit when we have setbacks. And so when we have those, you know, first few short cases and we don't do well, you know, are we saying things to ourselves that are then going to undermine our future performance? And, you know, so what this means is that for these exams, we need to really be thinking about, what are we saying to ourselves? What are we saying to ourselves now? As you're going through this, and you heard Judy talk about all the things you need to know. And, you know, I have to say, I haven't been through clinical training, but I was pretty overwhelmed just looking at some of those things. And I thought, okay, well, it's probably not as hard for you guys because you've been actually practicing this and doing this stuff for a long time. But still, I was thinking, my gosh, this must feel quite overwhelming. So the question is, what are you saying to yourselves when you're seeing Judy's slides about the things that you need to know? Are you thinking about, okay, well, there's a process for learning this, and I'm getting good tips from Judy about that process, and how should I set up that process, and who should I work with, and who should I talk to? Those are all growth mindset ways of thinking about it, where you're thinking about your strategies and optimizing your process for getting good at something. If you're thinking about, I'm just not smart enough to do this, there's no way I'm going to know all of those things, there's no way I'm going to do this, do I have what it takes? Do I have the smartness to do it? Those would all be kind of fixed mindset sorts of things. And so you want to think about the thoughts, what you're saying to yourself. And I have a picture here. This was when the US beat the Netherlands in about a year ago in the World Cup final. And I think a US player here completely decked a Dutch player who's lying on the ground. And for those of you who don't watch women's soccer, there's just a point I want to make here. If a woman's on the ground, she's hurt. Women don't do this stuff that the guys do where they, you know, roll around with all the dramatics and then 2 minutes later they're up and they're fine. That doesn't happen in the women's game. If she's down, she's hurt. But the main reason, aside from making that side point for you, the key reason why I am showing this here is for the referee, the woman in the yellow jersey. I've done some refereeing, and my husband has done a lot of refereeing. And one of the things that we talk about is if you think that, you know, maybe there was a foul that you should have given, or possibly a game-changing call, like giving a penalty kick, which usually results in a goal. If you didn't make that call, and while the game's going on, you're still thinking, should I have done that? Oh my gosh, have I changed the course of the game? Do I belong out here? Maybe I'm not good enough to be refereeing. If those are the things you're thinking, you will miss the next call. You will miss the next thing that's happening. And you know, your game might end up just getting worse and worse and worse. And I think it's very similar for the clinical exams that you'll be doing, is if you're ruminating about what happened in the last short case, that's going to affect your cognitive capacity. You know, we do have, you know, at any given moment, we have a set amount of cognitive capacity. And it's kind of like using up battery power. And if we're using up some of that battery power, thinking about what happened before, where there's nothing we can do about it now, that's wasted energy. And so you really want to be able to just, whatever happened, even if it was a disaster, just put it behind you and keep going, is from a psychological perspective, a key piece of advice that I would give. And as Judy said, you're going to have opportunities to make up some of those points. So you want to give all that cognitive capacity to what's coming next. Now, an important thing to know is a fixed mindset is not fixed. And so, you know, maybe you've gone through, you know, your academic career and done really well, and you've been praised with fixed mindset sorts of praise, like, oh, you're so intelligent, you're so smart. And then you somehow managed to get through med school without getting too scuffed up academically. And, you know, maybe you've developed kind of a fixed mindset about these things. Well, the good thing is it's not fixed. And if you generally have a growth mindset, it's also important to know that any of us, even though we have a growth mindset, can have fixed mindset moments, particularly when we're in challenging situations. So, you know, preparing for your clinical exams and taking these clinical exams, no matter how growth mindset you are, you will probably have fixed mindset moments. And so I'm going to give you some advice for having more of a growth mindset. And so the starting place is, you know, keeping in mind that science supports some malleability in the brain and that the brain changes with experience. You know, we used to think that the adult brain was very fixed, you know, and all we had to look forward to in our future in terms of changing the brain was going to come from head injury or dementia. And now we know that, no, there's a positive side too, and there are ways in which we can change the biology of our brain through practice and experience. And we know that because there have been experiments where you randomly assign half the people to take violin lessons a few times a week and practice the violin, and half the people don't do that. And you do MRIs on them before and after that training or that control condition. And you find that the people who are practicing the violin, that the parts of the brain that control the finger movement on their left hand, that part of the brain has more neurons in it, that it's denser, and that that part of the brain that territory that controls the fingers on the left hand may have even expanded a little bit. So we know from these experiments that even as adults, as we learn and do things, we can actually change the brain. So kind of just reminding ourselves that the science supports, is much more supportive of a growth mindset idea. And it's not like we have the brains of 2-year-olds. It's not that plastic, but we do have some plasticity. But the other thing that we need to do is sort of develop a growth mindset through practice. And so we need to listen for the fixed mindset voice. And I don't mean this in an auditory hallucination kind of way. I mean that we talk ourselves through things all the time. If you're doing that for short case, you're saying to yourself stuff about how you're doing. Right? When you're practicing this and maybe you do a practice with med students, as Judy suggested, and it doesn't go well, there are things you might be saying to yourself that could make it harder to you to move forward because they're more fixed mindset voices. So let's just look at that a little bit. There's 3 places where we're likely to hear the fixed mindset voice. So when facing a challenge, that's what you're doing now, right? You're preparing for these exams. You're definitely facing a challenge. The other times when we can hear fixed mindset voices are when we have setbacks and when we get criticism or hear negative feedback. So facing the challenge, as you're getting ready for these exams, you might be saying to yourself, what if I fail? I'll be a failure. Maybe I don't have the ability to do this. Maybe I'm not smart enough. And, these would all be natural things for us to catch ourselves saying. And the key thing is that notion of catching ourselves. When you hear that, think, well, okay, that's a pretty fixed mindset way to think about it. What's a growth mindset alternative? And some suggestions would be, I might fail. Some people, fail these things and go on to be great doctors. At some point in my career, there will be mistakes, there will be failures. And you may even be able to look back to setbacks that you had in medical school or earlier in your training and recognize how you got through those difficulties to realize, look, this is part of the process. You might say, right now, if I had to take the exam, I think I would, probably have a hard time and fail. But if I prepare correctly, then I up my probability. Then there's the issue of, if you have a setback. So if something happens that interrupts your study, and we're all dealing with that because of COVID, right? These are really, going through these exams are tough experiences under the best of circumstances. And then you've had all this uncertainty thrown at you. And so we're all experiencing setbacks with this. But, when you have a setback, so either you do some trial exams or practice exams and they don't go well, or you actually do the actual exam and you don't make it. And you need to start preparing, thinking about what's your next step, and will you take it again, and how will you prepare? And so if we have that setback, a fixed mindset thing that we would say to ourselves is, boy, that would have been a snap if I really had talent. Or I knew it was a risk. Now I've shown the world how limited I am. I went for this specialty. I knew that it would be hard. And now, I've embarrassed myself. And I think for a lot of us, one of the things that's really challenging about these exams is it's really public. People are going to know, and your family is going to know. And I know for some of you, particularly if you've come from other countries where your training has been quite expensive, it's been an extended family that's kind of chipped in financially for you to be here. Or if people haven't invested in you financially, they may have invested emotionally in you. And so you might feel like, oh my gosh, I'm going to have to tell them that I failed, and I'm going to have to be embarrassed, but also I will let these kind, wonderful people who I love, I will have let them down. And so these are all kinds of fixed mindset sorts of things and pressures that we can put on ourselves. And one thing you might want to do with that is you could start preparing the people close to you for the fact that this is a process, that, you know, these are hoops that you have to go through and hurdles you have to go over. And sometimes you trip on a hurdle and you get back up and you try again. But, you know, it's kind of realize that, you know, these kinds of setbacks are likely inevitable. If you haven't hit one yet, you probably will, and it is part of the process. And so if you hear yourself after a setback saying, well, that would have been a snap if I really had talent, or I knew that was risky, think, you know, what are more growth mindset thoughts that we could have had. And so this would have been a snap if I really had talent. You know, tell yourself that's wrong. It takes a lot of practice to get good at this. You may remember back to when you first started doing clinical work, when I talked to the third-year medical students who were doing clinical work, and I asked them, you know, what's a setback? What's a bad day? And they say, when you try and cannulate a patient and you try 4 or 5 times, and now the patient's in tears and they're asking you to stop. And then the nurse steps in and does it like it's nothing, like she could have had a blindfold on. That's sort of a bad experience. And part of why that's a bad experience, and if you can remember back to that stage in your learning, part of why that's a bad experience is you say to yourself, oh my God, I have book smarts, but I don't have manual dexterity. I don't have procedural skills. Oh my God. What will I do? I'm going to need to be a radiologist or a psychiatrist. Not that there's anything wrong with either of those professions, but that's what you might be saying to yourself. And of course, that's a very fixed view. You tried to do something that's difficult. You had trouble. Someone else could do it easily. And so we think, oh, gee, if I had talent, I would have been good at this. No, we should be thinking, well, this nurse has probably done this thousands of times. I've done this, you know, 6 times, and this is the first time on a live patient. What do I need to do to get more practice opportunities? Could I ask the nurse for help? Could I ask one of my peers who is doing, seems to be, you know, not having too much struggle with this aspect of their training? Could I ask them for help? And so when I say a growth mindset response, it's much more about the process, not a self-diagnosis. You know, I have it or I don't. I have procedural ability or I don't have procedural ability. It's much more, you know, how do I get good at this? How do I practice this? And if you had put your hand up and said, I'll try and cannulate that patient, and then it didn't work out, you might feel that it's embarrassing, but also realize, hey, by taking a risk, I've now gotten a step ahead of some of my peers by having had this experience. And I think, again, if you get knocked back on the exam, you know, to be able to tell yourself, well, some people need a go or two at this to make it happen. And, you know, if you start worrying that people are going to look down on you for it, as Judy said, it's not something people are thinking about that much as we think they are, our peers, our colleagues. But also realizing, hey, you know, I went for a difficult specialty where you need to know a huge range of information. It's very difficult. It was a risky thing to do, but I'm getting good at something that's very difficult to get good at. And then when you get negative feedback, and you might get this, you know, this week, you'll be working with a patient and someone supervising you, a senior person, might say, hey, I noticed you did this, and look, a better way to do it is to do it this way. And there are kind of 2 things when we have a fixed mindset reaction to feedback. There's kind of 2 directions we can go. One is defensive. It's not my fault. It was something or someone else's fault. In other words, because of the fixed mindset, the person's thinking, if I take this feedback in, it'll mean maybe I don't have it. And that would be a huge blow to identity. And so there's just defensiveness. And they might not consciously think all this out. It could all happen really quickly, but what you get is defensiveness. And if you ever try and just give a little tip to a junior person who has that fixed mindset, I'm sure you've all had that experience of, they don't seem to want to take it in. They don't seem to want to hear it, and it can be frustrating. By the way, a little tip on giving feedback to a fixed mindset, a person who's operating with a fixed mindset, would be to put it onto the process. It looks like you're struggling a bit with this. I struggled with that too. You know, it's part of the process of learning this. It's a hump that you have to get over. Here's what I did to get over the hump. Okay, that sort of feedback, sort of putting it in the context of a process, it kind of takes it off the person personally and might make them less defensive. The other thing, though, that people can do when they get negative feedback is feel like, oh God, the person's disappointed in me. You know, they picked me for this internship and now, you know, I messed up and they think they made the wrong choice. And this is where imposter syndrome can kind of come out. Oh my God, I've been discovered, right? And we might see this exam in that light that, you know, if we sort of have always been thinking, well, I'm pulling it off, you know, deep down, I'm not sure I'm capable, but so far I've pulled it off. Everybody thinks I'm okay. But oh my God, with failing that test, then the veil will be lifted and people will know I'm incompetent. And again, this is a very kind of fixed mindset thing to think about. So, you know, people recognize that qualifying for the senior levels of this profession is difficult. It is not without setbacks. Everybody that you're worrying about how they judge you has had their own setbacks and their own difficulties and their own rough journey to get there. And it's made all of them a better doctor, and it'll make you a better doctor too. And so you want to, you know, if you feel like you're being defensive to feedback, recognize, hey, if I don't learn, if I don't take some responsibility, then I won't learn anything. So I need to listen. And also remember, you know, when people take the time in their busy schedule to give you any kind of feedback, that's actually something to be grateful for, because you're being mentored. Somebody's investing their very minimal spare time in helping you out. Okay, so the key takeaways from here are what we say to ourselves matters. Try to see the disruptions that we're going through because of COVID and how you're adapting to those as a process. Realize that others are adapting too, and we all need to have a little bit of flexibility and cut each other a bit of slack, because everybody's dealing with a pandemic of this scope for the first time and what it means for training. And if we spend a lot of energy being angry at others, that's probably unnecessary energy. But also just, you know, we're getting better and better at adapting to this changing world that we're living in. And that's going to suit us well for the future. But also recognize the pressures that you place on yourself, your perception of family expectations, your self-expectations, what you're thinking about your colleagues' expectations. Just kind of examine those mental models of how you think other people are going to be looking at you, and question them, and realize that the people around you, the people who care about you, they know what you're doing is really hard. And if they don't expect that you're going to have some setbacks along the way, they're going to adjust to it pretty quickly. And I say this to our graduating students, and I'll say this to you, because we do worry about how they go on to internship, and we know that it's a dangerous time for junior doctors at internship time in terms of mental health and well-being, and even issues like suicide. And just one thing for those of you who are particularly worried about the family expectations, one thing I would say is there is no career failure or career setback that would disappoint or hurt your family more than losing you, right? What matters is that they love you, and they will love you, and they will care about you, and your colleagues will respect you based on the image you have created and the person you are over all these years. And it doesn't hinge on one exam. And even for very few of you who end up going into a completely different career path because you don't get over those hurdles, trust me, you'll end up liking that career path. We are really good at making the best of where we end up. And you could find doctors now who took a different career path, maybe because of an exam setback, maybe because they just realized they were in the wrong place and invested in getting into the right place, who'll say, yeah, when I was at this stage in my career, I had no idea I would love doing what I'm doing now, and I love doing what I'm doing now. So just realize that career paths are meandering and curvy, and they're not a straight line. And I think that's a really good thing to keep in mind. And then just to finish off, some other resources that I have. So I've made a bunch of resilience videos. So these are sort of how to manage in situations of adversity, like having your exams postponed. So this is a good time for all of them. Here's the link to get to that page. If you only have 8 minutes to do this one. Have a look at the meaning one. I think that's the most relevant for the situation that you folks are in. Some videos that I made during a soccer expedition I went on to make a world record. We got a Guinness World Record for playing the lowest altitude soccer game ever played by any gender, but we did it all women. And I made some growth mindset videos along the way. Some TED Talks that I would recommend. A stress one I think is really, really helpful for folks in your situation. And so I'm gonna unshare my screen here, and I'm ready for some questions and discussion.
Thank you, Jill. So we have a few questions popping up. So the first question is, how can you keep yourself composed and stress controlled throughout the actual clinical exam? How do you keep your cool if you think you did really poorly on a case early on and not fixate upon it for the rest of the exam?
Yeah, so what you need to do is just the second you catch yourself thinking about it, just stop. Just stop and say, oh, just direct yourself back. And it's the same technique that you use in meditation or mindfulness training. And it's a skill that we do develop, which is just cutting off our thinking when we recognize that we're having unhelpful thoughts, cutting it off and moving to something else. So one thing that you could do is, you know, take a meditation class, and there's tons of online stuff right now, and there are tons of apps that you can get for your phone, and I'm sure some of you are already doing this. And you know, I know that for some of you, meditation stuff sounds like, well, let's get out the crystals and sing folk songs too. But you know, it now has like this huge amount of science behind it that mindfulness techniques and meditation techniques are really helpful. And for the exams, the meditation technique of what do you do when you're supposed to clear your mind, which sounds so much easier than it actually is. What do you do when thoughts intervene, when you're trying to keep a clear mind or just focus on your breathing or whatever you're doing in your meditation? And basically what you're supposed to do is recognize, oh, that thought impinged. Don't like beat yourself up. Oh my God, I let a thought in when I was supposed to have a clear mind, right? It's a process of getting good at it. Recognize that the thought came up, you know, let it pass by and get back to that stillness and that emptiness. And I've done some mindfulness training, I do yoga and stuff, and I still, the thoughts just keep coming in all the time, but I have gotten better at not hitching a ride on the thoughts and then ruminating with that thought, but saying, oh, that was a thought, letting it go by. And so if you can do some of the training, spend a little bit of time doing some of the training to do that before you take the exam, that is probably time well spent. Not only is there evidence that that's good for your well-being, particularly when you're going through a stressful time. So for that reason alone, it's a good thing to do. But it'll also help you develop some of those mental control skills so that when something does happen and you're ruminating about it during the exam, you can try and move on from it. One technique, so we tend to think that we can multitask, we can do two things at once, but we actually can't. And research really clearly shows us that multitasking is a myth. And what people are doing when they think they're multitasking, so if you're listening to to this session while you're also doing your email or studying some cardiology topic or something like that, and you're trying to do both at the same time. Actually, you're just switching back and forth. And research clearly shows us that when we try and multitask, we lose time, so we waste time, and it makes us more stupid. So for the moment, we lose our cognitive abilities while we're trying to multitask. So we get slower and dumber while we're multitasking, and we're much, much better off just devoting our attention to one thing. And then when we're done with that, doing the next task. We will be faster and better at the task by doing that. Now that's cognitive tasks. We can do a procedural task that doesn't require a lot of thinking, like riding a bike. So a procedural task that's really, really easy for us. Some of you may have seen surgeons, very senior surgeons, who are doing a task that you would have to use all your cognitive energy to think about what you're doing, and they're doing it while they're chatting about something else. And that's because it's become a well-learned procedural task. So we can all do things like clean our kitchen while we're doing something cognitive. So that's fine, but we can't do two cognitive tasks at once. And so one thing that we can do when we find ourselves ruminating is do simple math. It turns out when we do simple math, we can't think about anything else. So if you start counting backwards from 1,007s, so 993, 986, if we do that, we stop all cognitive rumination. We cannot think about anything else. And so that's good. And it's actually a technique that's used when you struggle with anxiety or rumination, is to just do that cognitive task. And if you started counting backwards by 7, you might have thought, well, how hard is that? And you started doing it, you stopped listening to me. And then when you started listening to me again, you stopped counting. And so the idea is if you're kind of ruminating about something and you do that counting, you might find you drift back to the rumination, but then you can catch yourself and say, oh, I got to get back to my counting. You go back to the counting. Now, that's a technique that you could use in those, little bits of time between the different pieces of the exam. So you could, if you think, oh my God, I messed it up, instead of spending those few moments ruminating about that, count backwards by 7s from 1,000 and just, get back to, a calm level. I don't recommend you do it while you're interviewing the next patient or doing the history on the next patient, because you will not remember anything the patient said. So it's a good technique to use between the pieces of the exam, but not during. But I would say, again, just getting a little bit of practice, a little bit of training, and you can do this with your phone and with apps, of sort of being able to push thoughts along in your mind. That would be a good skill to have.
How do you keep composed leading up to the exam and the preparation process?
Keep composed leading up to it. Right. So again, you might find that when you're studying, you start getting fixed mindset thoughts. I'll never learn all this. I'll never know everything that I need to know. And by the way, you probably never will know everything you need to know, which is why most people don't get perfect scores on this test, but you still pass, right? So knowing everything you might possibly need to know is probably something that's out of reach and an unfair standard. But certainly you want to be feeling like you're getting down what you need to know to get through this hurdle. And so I would say that if when you go to study or in the middle of your study, you realize you're ruminating on what you don't know and what would happen if you failed or if you can't do it, and you catch yourself doing that, man, start counting, start doing something else. And you can do anything to relax yourself. Maybe that's the time you have a little folder on your desktop with the videos of kittens playing piano. I don't know, whatever makes you laugh or distracts you. If you have little children, go hug your kid. I have a Cocker Spaniel sleeping right next to me. So sometimes I'll just go have a moment with the Cocker Spaniel. But, if you're finding that rumination, just, put in a break, move away from it. The quick one is the counting backwards, just do some other task. And then the thoughts you should replace it with are, okay, I may make it, I may not make it. What is the best way for me to get there? You know, what is the best process for me to get there? Now, one of the things that I mentioned in the video that I suggested is that we often feel very, very stressed and overwhelmed if we look at all of the challenge all at once, all of the demands of a situation. And I can see, you know, when you think about everything you need to do to be prepared for this exam, that it could just feel overwhelming. And the key thing is break it down. What, if you're feeling overwhelmed, what do you just need to do in the next half hour? What do you need to do in the next hour? What do you need to do by the end of the week? And this is why a good study plan can be really helpful. Not only does it keep you organized, but it can allow you to just focus on the here and now, as opposed to the huge, big picture. Because we tend to be in threat mode if we feel like the demands of the situation are bigger than our resources. But if we break down the demands, that can really help. And I'll just give you a really quick side story of an extreme example of someone doing that. And the person doing that is my father. My father's 92 years old. He's still in great shape. And he's a Holocaust survivor. And when he was 16, he was in a Nazi concentration camp. He was in Auschwitz and then sent to slave labor camps. And he'd been separated from his mother and two sisters, and his father had been killed at Auschwitz. And he's on his own, and he's going through this slave labor on starvation rations, and people are dying around him. And, you know, he kind of thinks about, how am I going to think about this? How am I going to keep myself going through this difficult situation? And he gave himself a goal. You know, why does he want to keep going? Which was important to keep in mind, because it was, every day was just so painful and so difficult. And so he thought, well, I'm going to have the optimistic view that my mom and my two sisters are going to get home. And I know my father's dead. And if I don't come home, and so they lose the dad and the only son in the family, that's going to be just so awful for them. I owe it to them to get home. And so that was his motivation. His other motivation was he saw it as a contest. And again, our situation, as hard as it is right now, is worlds away from his situation. But, you know, my dad tells his story, and he speaks to audiences, and he teaches about resilience, because he feels like if anything can come from his experience that can help us, and particularly doctors, he loves when I tell him that I've told his stories to doctors. So I know that this is, our situation still is a long way from his, but maybe this can still help. But, you know, he thought about it as a contest, and he thought about it at, if he dies, then they win. And he didn't want the bastards to win. He didn't want those Nazis to win. He wanted to be the winner. And he knew that if he survived, then he would win. And so those were his two motivations, this really personal, I want to win. And then outside of himself, I want to do this for my family. I want to get home to my family. But even with those strong motivations, it was his situation, the demands of the situation were friggin' overwhelming. I mean, just, you know, slave labor and starvation rations where people were randomly getting picked out to be beaten up. And there were all sorts of just random things that were happening that were horrible. And so what he did was he broke it down. In our world, we say, take it one day at a time. In his world, he said to himself, when he woke up in the morning, I'm going to get back here at the end of the day. And when he went to sleep at night, he said, I'm going to wake up in the morning. So he broke it down into manageable pieces. And as he got through each of these half days, he kind of patted himself on the back saying, you know, I had some strength to get through this situation. And so I think if we're feeling overwhelmed when we're studying, it's really important to just break it down into little pieces and cope with one piece at a time. And then keep your motivation in mind. You know, why are you doing this? And you know, try and have some motivations beyond just the test. As Judy said, you're going to learn so much through this process. And you know, try and have that broader motivation. You know, this is going to make you better in working with patients. And just very quickly, because people often ask me, his mom and 2 sisters did survive, which was, you know, astronomically small odds that something like that would happen, that 4 out of 5 in a nuclear family would come back. Out of his extended family, 107 people went to the camps and only 7 returned. But his mom and 2 sisters did return. And of course, it did matter tremendously to them that he got home to them.
Thank you, Jill. That was a very heartwarming story. The next question is, how do you mentally deal with a consultant who is particularly harsh in their feedback? Afterwards, you end up feeling deflated and losing confidence in your ability.
Yeah, that's really tough. And, you know, one of the things we do at the medical school is we teach doctors how to be teachers. And so one thing to remind yourself is that most consultants have gotten no training in how to give feedback or how to teach. And so that harshness probably says much, almost certainly, like says much more about them than about you. So look, and I'm not saying, look, just suck it up, you know, maybe the culture where you're working stinks, but just suck it up, because that culture should change. And people shouldn't be harsh in their teaching. But unfortunately it is, and we are doing a lot of work. I teach a leadership program. We are doing a lot of work to help that culture change and help individuals change. But we're not going to wipe out, you know, fix all the harsh consultants overnight. And that's still going to be part of your training. Just try not to become one. But if you get that harsh feedback, so recognize that has more to do with them than to you. That's probably their style. It may not even be a reflection of how they're evaluating you or how they see you. It may just be their style. Or you did have a particularly bad moment, and everybody does, and they see that all the time. So just try not to make it seem like too much of a big thing. Try and pull out, okay, he's mentoring me or she's mentoring me. They're not doing it in the style I would appreciate, but what is the kernel of information there that I could use to become better? So, you know, try and say, what is the piece that I can take responsibility for? And if I could do it over again, what would I do better? And we all have this. I'm writing a book with a co-author, Vanita Rain, called Thriving in Medical School. And it's a well-being book for medical students. And we presented it to a few colleagues yesterday, and it was a Friday afternoon meeting, and we were taking up some time in their meeting, and we kind of thought, oh, this is so cool. This is that they would say, oh, that's so great that you're doing this. And they were kind of like, meh. And, you know, we had to debrief afterwards and keep each other going, because we were like, well, and no one was mean to us, but no one was like nice and encouraging either. And so we got together and we built each other up, and we each talked to people afterwards who are excited about the book, so we could remind ourselves, yes, we are on the right path. But we also were able to think, you know, why didn't we get a more positive response? And should we think about, you know, our 5-minute elevator pitch of the book? If we've got to convince people of why this would be a good book for our students to have and why they might want to get involved, maybe we need to work on that pitch, because clearly it didn't go over very well. So, you know, you support each other, you help each other, you recognize that there are some things that are beyond your control, but you also look at, well, what is the signal here? And if I could have prepared for this meeting over again, what would we have done differently? So I think that balance is really helpful.
Thank you, Jill. I'm just aware of time, and we've got
Sure.
a list of questions actually. Should I keep going?
I think it would be best probably, I've got some questions from previously too. So I think we were going to finish at 11:30, weren't we?
Yes.
So would that be okay? Jill, could people write to you if they had questions?
Yes. Well, I think what you could do is go ahead and put them in the chat or the Q&A.
Yeah.
And Pavitra, if you could then send them to me. Do you know how to capture a chat, right? Yeah, okay. If you could send them to me, then maybe what I'll do is I'll make a little video and I'll tell you with the answers, and then that can be distributed. Because of all the Zoom work and computer work of this lockdown, I now have a repetitive injury with my shoulder and basically can't type or edit videos. So I will tell you, it will be rough. It'll be not pretty, but I'm really happy to just record answers and then pass that over, and then it could be distributed out to you guys.
Okay.
Thank you, Jill.
Thank you.
Sure.
Thanks. Okay.
And so I'm going to slip out now and hand things back to Judy. So thank you all for your kind attention, and good luck with everything. And where you are now, you've been amazing, and there's all kinds of directions that you can go in. So just hang in there. Take care.
Thank you, Jill.
Okay.
Video is off. Yeah, perfect.
Okay, great. Look, there were just a few questions from before I thought I might answer also. So I think if the people who are attending could just know that we prepared the date for this session when we thought the exam might be at the end of this year. So there could have been 6 months. So it wasn't as though it might be, and it's probably going to be next year, but although we don't know. So you do have a long time until you're going to have the exam. And I was asked, how do you focus and concentrate? And I've said, there's little things you can do. So even if you just prepare your template for your long cases and use that whenever you do your admissions from now on, then you are preparing for your exam. If you say to the medical students, I'll give you a tute, and the medical students rotate around. So you might only have them for 6 weeks or so, but if you get your short cases ready there too. So there are things you can do that are not going to be consuming every minute of your day. You are going to get a lot of positive feedback from the medical students. So it's that kind of thing that I would say you can start to do now. And then when you go into the exam, you can say, I was really strategic about this. I didn't work myself into the ground, but I was clever about how I prepared for it. And I really couldn't have done it any better. It's not about putting, so many hours into this. It's about, I addressed the areas that I was weak in. I made up on my list of short cases and I prepared for them. And so you go into the exam saying, I was smart about this. So that will help with your confidence too. I was also asked a question about negatives and how you discuss all of the negatives in your long case or even in your short case. Some candidates will concentrate on the system that has the abnormality. So they might just say, in the cardiovascular system there was so-and-so and there were no abnormalities on examination in the other systems, and do it that way. But I think it's good to have relevant negatives in there too. So if you think this person has diabetes and they've been a smoker and they really are at risk of vascular disease, but now they've come into hospital with MS or a neurological condition, but you want to make the point they've had diabetes for 20 years, I think you need to say which complications they have and they don't have. And you can do that quite concisely. So you don't have to dwell on it, especially if it's not going to be your major issue. But of course, if the person can't walk because they have such a bad peripheral neuropathy or they've had an amputation, etc., then you can spend more time on it. So I think discuss your relevant negatives. And some candidates, I can't say that they're necessarily the best, but they often are very good. They will focus on the system that has the abnormalities and discuss the relevant negatives there, and then dismiss the other systems as one, rather than saying, the pulse was in sinus rhythm and blood pressure was so-and-so, but actually do it focusing on the abnormal area. So again, how do you build up confidence? And what about if things go wrong in the day? You just think that was the case I was supposed to get wrong. Jill's talked about some strategies you can use of just moving on. You can say silly things in the exams too, and we get it not uncommonly. For example, somebody does an abdominal examination and there's a spleen, and they'll say there's a mass, and they'll say it's under the right costal margin, and it comes down and it hits my hand, you know, it's moves diagonally, etc. But they'll get the side wrong. When you start out, we know you're very anxious, and you know you've just spent 4 minutes tucked up under the left costal margin. We know you know it's not a liver, so we just ignore the fact that you got the side wrong. So you can make little mistakes like that, and we don't care. And you know, even the important thing is to get the big questions right. So don't worry, and don't worry if you can't get an answer sometimes. You know, you mightn't quite understand what the examiner is getting at. And usually the other examiner will step in and say, look, let's move on, if the first person gets bogged down about it. Now, I know time is moving on, and I'm sorry to take a few minutes over that, but the final thing I wanted to talk about was how to write a case report. And again, we didn't know what was happening with advanced training. And we wanted to, I know a lot of you have case reports. I know a lot of you have written papers already and done research as part of your undergraduate degrees. But I know some of you have interesting patients whom you'd like to write up. And what I wanted to do was to just go over some pointers about case reports, because they do go on your CV, and they may help you getting into advanced training. So I've entitled this How to Write a Case Report, but then I've changed it. To how to write a case report quickly, efficiently, and get it published. Because there's really no point in writing up a case report if it doesn't get published. So I just want to give you some tips on how to make sure you do get it published. I do think case reports are valuable. I have seen, you know, a case report gets written up and then people notice the association. Maybe it's about a treatment that worked in one person, and then that people do a clinical trial, they can expand it. But case reports, in my experience, are often telling us something about the pathology of the disease that we would never have guessed at. And sometimes they teach us something about the treatment, so they can be very valuable. Now, a case report can be novel, so it could be something that hasn't been described very often in the past, or it may contain a teaching point because it may illustrate something, there's a lesson to be learned here. Case reports don't drop off the bottom of your CV, so that even if you're going for a senior position, that case report while you were in your basic training will still be on your CV, and they will help throughout your career too. And you'll also learn how to write and to publish and to encourage your registrars to write case reports too. But it's wonderful to feel part of the community where you're contributing to medical knowledge, and it's a bit of a thrill to explain and to describe something for the first time, even to get a publication in it, especially in a journal rather than in a as a poster. So what should we publish? As I said, there's two kinds of case reports. It can be a novel observation or interpretation. It could be a new clinical feature. It could be a temporal sequence that suggests a cause. It could be a side effect of a medication. But it can also be a teaching point. And I'm going to emphasize this a bit because this means that it doesn't have to be a rare or new feature, but it can be a case that presents a diagnostic, ethical, or management challenge, or indicates a mechanism of injury, pharmacology or pathology. And it could be that there's something to learn from this case report. So I just put up a few case reports that I've had my registrars write up, and I'll show you how they're not really enormous leaps forward for mankind, but also how, because they were in the areas I work in, that I knew there was a gap in the knowledge there. So one of my registrars wrote up the first description of a lupus anticoagulant and thrombosis in an ANCA-associated vasculitis. And this was in a person who was 70 years old with Wegener's or a GPA and a C-ANCA, who'd been treated and then 2 years later came into hospital with a DVT and on testing had a lupus anticoagulant. But the C ANCA was actually negative by that time. So we kind of looked at this and thought about it. So this was the association of ANCA with a lupus anticoagulant. Anticardiolipin antibodies had been reported before, but nobody had described a lupus anticoagulant. And anticardiolipin antibodies, I think, were negative in this patient, but I can't remember. And what happened was that both the antibody and the thrombosis developed years after the vasculitis presentation, when the vasculitis was inactive. And when we went back and looked through the previous reports of anticardiolipin antibodies, it was a similar story, that the antibodies developed years after treatment, including treatment with cyclophosphamide. So that was what was novel about it. So we were saying, if you have a patient with vagus granulomatosis and they get a DVT, when the disease is well controlled, you should be thinking about these antibodies, and they probably are part of the whole syndrome. Don't think it's just coincidental because the person was sitting in front of the TV and fell asleep. So this was another one. In fact, we had two patients who were very similar, and this was the association of ANCA vasculitis and a staphylococcal wound infection. This was a patient who was in hospital, and he was in hospital for probably about 10 weeks, which mightn't happen now. He had a myocardial infarct. That was why he came into hospital. He had CAGs done, and he developed a sternal wound infection. And then his renal function started to deteriorate, and he got some macroscopic hematuria. And he was tested then for ANCA, and we could go back and show that his ANCA was negative when he came into hospital, and he had normal renal function, and he had no hematuria. So what we had here was a temporal sequence that suggested the role of staphylococcal infection in the development of ANCA. And we already knew that nasal staphylococcus had been implicated in the pathogenesis of ANCA vasculitis. So we had another similar case with a person who had bursitis, an elbow bursitis with a staph infection, and also developed ANCA and vasculitis. So both of those patients were published. And subsequently, somebody showed that the sequences, I think it's the staph and the ANCA antigens were similar. It's not exactly, it was a very specific staph, but they published that in Nature, and they quoted our paper on that. So this is an example how an observation, when you're thinking about it, can help explain a little bit about the pathogenesis of a condition, to also put the idea into someone's mind. Now, the last case I wanted to describe was of a registrar. We had a patient who had anti-glomerular basement membrane disease and had normal kidney function. And I said, why don't you go to the lab and see how many other anti-GBM antibodies have been detected, and see how many other people have normal kidney function and write them up. And she went to the lab and she found over the previous 20 years there'd been something like 10 patients with anti-GBM disease diagnosed. And of those, most of the patients had never come to the renal unit. They'd all been diagnosed on lung biopsies, and they had normal renal function. So again, that was a nice series just from an observation on the ward. So how do you tell if something's worth writing up? It can be difficult unless you work in the area. And I was working on ANCA vasculitis at the time. So you can present your patient at a unit meeting or a grand round and find out if the observation's novel or a suitable teaching point before you're doing all of the work for a manuscript. So you've done some of the work, but you had to do it for the unit meeting or the grand round. And find out what the local experts say. You've done a literature review, but do people say, gosh, you know, I've never seen that before, or what's that telling us, etc. So you may get some information from the local specialists in that area to say that this is actually quite unusual. They may just say you should write this up. Now, if you do a quick literature survey and you find that there's 15 patients have been written up with exactly the same story, that may be a disincentive. But I can say there's often subtle differences from the previous reports. So, for example, with our lupus anticoagulant, we were able to say that anticardiolipin antibodies have been associated with thrombosis before, and they were not found when the person had active disease. So we were able to use that information, which was the same as ours, in our case and say, you know, now nobody had made the connection before, or the lack of connection. And nobody had noticed that before, but we were able to put that into our case report. And as I've said, it doesn't have to be a giant step for mankind. Showing a lupus anticoagulant when people had shown an anticardiolipin antibody, that's not an enormous step for mankind. But putting it together with the time inactive disease and making that association, that was kind of novel from seeing the previous reports. So where should you publish? And again, I would say be strategic, and I would say aim for an international journal. And that's not just because international is better, because it's not necessarily, but it can be very difficult to publish in some Australian journals just because they don't publish many case reports. And there's a lot of people trying. Whereas there is now the BMJ case reports, which are published. And these are online. I think they have about 10,000 case reports there at the moment. They publish very quickly and they're free to access. There is a downside though. You have to pay to publish, and I think it's more than $1,000. But many of your hospital libraries will have a subscription for publishing. And if they don't, you can always suggest it to them, because it's such a good idea. And so the hospital library may pay a subscription, which means that everyone at your hospital or your health service can then submit a case report without paying and have it published without paying. The other advantage of the BMJ case reports is that they accept 2 out of every 3 submissions. And that's a much higher acceptance rate than most places. And the other advantage is that it, because it's online, it publishes very quickly, so it's in press, accepted quickly and published in press. So I've put the web address there. And a final advantage of the BMJ case reports is that they are interested in teaching points. So you may have, as we had last week, a patient who had generalized lymphadenopathy and was in the ward. He came into hospital, he had a DVT, generalized lymphadenopathy, and we wanted to get a lymph node biopsy because we thought it's probably lymphoma, and we referred him to the hematologist. We did a PET scan, etc. But then the histology came back and actually it was widely disseminated SCC. So the reason I'm telling you this is it looked like lymphoma, but it wasn't. So that's a teaching point. And if you write it up well enough, it's such a reasonable thing to say, you know, just remember, it doesn't have to be lymphoma if you have multiple lymphadenopathy like that. So that was would be suitable as a case report. So the format of the manuscripts is similar for all of the journals, and you really can write a case report up without knowing which journal you're going to submit it to. You will need a signed consent form from your patient, which really just says that the patient is happy for you to write them up. You will de-identify the patient, so there shouldn't be anything that would mean that people knew that it was that person. But otherwise, the layout of the manuscript submission is all about the same, and including, I've highlighted some areas there, acknowledgements and conflicts of interest. We usually use EndNote for the references, but I've made a few points that I'll refer to later. It's good, if you have decided which journals to submit your paper to, I'd ask for help from a consultant who's seen the patient, who knows the patient, and who writes a lot with registrars. If you ask the other registrars around who's good to work with, they'll probably know. And there are some consultants who particularly like doing it, and who are good at doing it. But it's better if it's a consultant who's looked after the patient. You wouldn't go and ask somebody from a different unit in general to help you with one of these case reports. So choose the journal you'll aim for, and then have a look at the journal and print out a couple of manuscripts in that journal that are similar kinds of cases to yours. They don't have to be the same kind of case, but similar, like maybe a teaching point, or maybe a novel observation, or something like that. So you get a bit of an idea for the construction of the manuscript and what goes where, and how you make your impact, how you make your point about what you're doing. You'll even get some tips, like if they have a teaching point, what kinds of, how do they phrase what this teaching point was, etc. You'll need to get all your results together. Often you'd have an X-ray or histology. You need to complete your literature search, and you need to work out the angle. So if this is going to be a teaching point, what's the major teaching point here, and what are you going to put in? In writing up your case report, write them up exactly as if you're presenting to a unit meeting. Often the introduction and discussion, they're a bit interchangeable. So you might write them together. There might be bits that you put from the discussion into the introduction. And there might be bits from the introduction you actually include in the discussion, but you won't repeat them. And usually we write the abstract last, since by then you know what the impact was here, and what your angle is going to be. So in the discussion, writing the discussion, I often, if I've got a complicated discussion, I'll use headings in my draft, and I'll put the relevant bits under each heading, and that just means you get a concise and very, you know, a discussion where you're not meandering all over the place. You can delete or you usually have to delete the headings before you actually submit the manuscript, so you don't have headings in the discussion, but they're good to just focus on each individual point of discussion. I usually start out the discussion in the first paragraph with the most important conclusions, because you want to get people in. You want to get them not just looking at the first sentence of your discussion, but reading the whole manuscript. And then you can dissect out the message and compare your results with previous reports, and you have to deal with any problems, like maybe it was critical to have histology, but you don't have histology, the patient refused the histology. You might even have a bit of discussion about that if the patient refused something or something's not available for some reason. You talk a little bit about the implications, and I keep on coming back to the teaching point. Sometimes the publication will ask for something special, like a visual summary, which is like a cartoon, might ask for summary points. You'll have to write a cover letter to the editor, and you'll have to say why your manuscript's important. And you'll have to say in the cover letter that all the authors approve this manuscript, this version of the manuscript, and that they have no financial or other conflicts of interest, or you might have to say one of them does have a conflict of interest, and be very upfront about that. So some tips, what to highlight: be as concise and as clear as possible. Use as few abbreviations as possible. I usually say to my honours students, you're allowed to use 2 abbreviations in your thesis. With references, I'm sure you all know, always reference the first time a phenomenon has been described, and not a review that includes it or the last time you found it. If you describe something for the first time, you'll be very cross if everyone always includes the review that included your reference but doesn't use your name. So always reference the first time a phenomenon was described. That is the correct thing to do. Keep tables to a minimum. Don't repeat the text in the body of a manuscript if it's also found in the table. You can summarise it, but don't go through it word for word. Some don'ts. We're not allowed to say anymore, this is the first time this has been demonstrated, because there's been so many times when it's been a mistake, and it's actually the 15th time it's demonstrated. Don't say this is the first time in Australia, because we are the same throughout the world, and otherwise you'd have 200 different nations all describing pleurisy and pneumococcal pneumonia if they were describing it as if they were describing it for the first time. We tend not to use an historical perspective, so you don't say this disease or this syndrome was first described in 1958 by so-and-so. It's much more important to give the clinical features and the treatment rather than a historical perspective. And don't use previous authors' names. Try to dissect out if there's 5 papers that have described this previously. Try to dissect out what the messages of the papers are. So I've said here, don't say Dr. Green demonstrated fewer leaves in winter and Dr. Brown showed more leaves in spring. What you could just say is that in general, there are more leaves in spring than in winter, and then put the references afterwards. So that putting in, you know, so-and-so showed this, so-and-so showed that, it really detracts from the impact of what you're trying to say. Don't reference something we all know. And again, I'm afraid this is what my honours students do. They say humans have 2 kidneys. I say, well, you know, you don't have to tell us that. And this is, you're speaking to a sophisticated audience. I don't expect any of the registrars would say humans have 2 kidneys, but sometimes we do see things that are very basic that we all know. We learned in medical school that you don't have to reference. And don't refer to a case rather than a patient or a person or an individual with a disease. So even though I've spoken in my first talk to lots about long cases and short cases, in general, when you're presenting your patient and when you're writing up a patient, you will talk about a person with a disease, a person with diabetes, not, you know, most diabetics have so-and-so. You might say, you would say most people with diabetes have so-and-so. And you certainly do that in writing. So clear writing, be clear, aim to have the reader understand and remember what you've written. We always describe a disease. If you're giving a bit of background to the disease, we describe a certain sequence. And this is the sequence that is used in all of your textbooks, but you may not have realised it yet. So you start off with a kind of a brief definition, then prevalence, then etiology, pathology, clinical features, treatment and course. Something you may not have realised is that in writing, we use as few words as possible. So very clear, very concise, and don't double up on the words, and use active words as much as possible. Writing is very formal. Some words are never used. It's not casual. I've just emphasised here that we use Australian or British spelling. Doesn't matter if you send it to an American journal, they will change it. It doesn't matter. And they will change things according to style too. But we are Australian, so use Australian spelling. And just using the past tense to describe what happened. Authorship. The person who does most work, who is you, is going to be first author. And the senior consultant who helped you most is usually last author. I tend to include all the other people who've contributed. So other consultants, radiology, etc. And I just want to remind you that writing takes a long time. It will take a lot of effort. You won't go home and say, I'm writing up this case report tonight. You might, but usually you're going to have to review it. And the better the version you give to a consultant, the shorter the period of time it will take them to make revisions. So my rule of thumb is write something and then leave it. And you need to leave it for about a week. And you'll go back to it and you'll say, oh gosh, I used the same word 3 times in 3 sentences, 3 consecutive sentences. So you'll see things you didn't see before, or you'll realise that you've left something out. So it will be much better if you leave it for a break. You might say, could I leave it for 3 days instead of for a week? I've tried leaving it for 3 days, and you don't approach it with such a fresh mind if you go back after 3 days. Of course, you can do whatever you like, but I'm just giving you some advice to try to get the best you can. As I said, the better your final version, the less work for your consultant, and the sooner the manuscript will be submitted. So there's another kind of publication too, which is becoming very popular, and that's of a clinical photograph. For example, the New England Journal of Medicine publishes clinical photographs. So you just have to have a very nice picture, but usually it's more than that. Usually there's a bit of a twist to it. So maybe it's got a diagnostic feature in it, maybe it's got something unusual in it, but we take a lot of retinal photographs, and we've had retinal photographs published because they had diagnostic features that told us what the genetic disease was in this person that had been undiagnosed. So a clinical photograph is less work than a case study, and it can still be published in a high-ranking journal, but there does have to be something special about it. It's not just your beautiful pneumococcal pneumonia. So submission, the instructions are subtly different for each journal. The reference format differs for each journal, but it's almost always an online submission. You do have to get all authors to agree to the submission of this version. And how I do that is just send out what I think is going to be my final version, send it to them and say, if I don't hear from you by Friday, I'll presume you don't have any changes and I'll send it off. So that's kind of a bit of a way to deal with the fact that otherwise it might be 3 months before you hear from someone. So it's just an easier way to deal with that. So how do you make sure your paper gets written and published? Someone needs to be in charge, and you're going to have to be that person. One person does nearly all the work, and that's probably going to be you. And not everyone can write, but I think everyone gets better with practice. And as I said, make a deadline for the changes to the final draft from the other authors, with the understanding that if they don't get back to you, that they're consenting to the submission. Now, for people who are just starting out, they often get their manuscript and they say it was rejected. And I look at the letter and I say, oh, that's not a rejection at all, because the decision may sound like a rejection, but it's actually the journal almost never sends you back a letter and says, yes, we will accept this publication and publish it. What they usually do is they say, our reviewers have come back with the suggestions that follow, and if you make the changes satisfactorily, then we will consider, reconsider your publication, or if you feel you can respond satisfactorily to these suggestions, please do so. They kind of get out of saying exactly, we will accept it if you do this, but the interpretation is, if you do what the reviewers ask for, it's very hard for the publication to reject the manuscript then. Sometimes they say very clearly that even if you do make all of these changes, we still may not accept it. So now if your manuscript is just outright not accepted, in which case they might say, we receive many more good manuscripts than we can publish, and even if you responded to all of the reviewers' suggestions, we do not feel this is of sufficient interest to our readers, and so we will not be able to publish it. That is actually no. But in other circumstances, if your manuscript is not accepted, you may be able to argue with the editors. And I know that it's been a lot of people do. I haven't had a lot of success in it, but I've had a little bit of success. When there's been a mistake made, in particular, and you can say, could you please show this to an editor who is a clinician? And I've been able to get mistakes rectified there. And in fact, on one occasion, I was asked to write an editorial on what we had shown. And that was kind of the people trying to make amends for that original rejection. So consider the reviewer's comments, change your manuscript and send to another or more specialised journal. So that's the option if your paper has been rejected. It's usually a good idea, even if you're sending it to another journal, to correct whatever the reviewers have said. In fact, the manuscript may come back to exactly the same reviewers, and it's not going to be a particularly good look if you've not corrected what they've suggested be corrected. Now, if you really have had enough of this manuscript, you can submit it as a letter. A letter's less work, and it's better than no publication at all. However, don't think just because it's a letter, it's necessarily going to be accepted. It's just as hard sometimes to get letters accepted as a case report. So that may not be a terribly effective strategy. So that's all I had to say on that. Any questions?
Actually, there's one question. What journals would you suggest for clinical photographs, unique imaging?
So BMJ case reports is still good, and you can put in your photograph as part of a case report, but it depends on your specialty. So a lot of the specialist journals now are taking clinical photographs. If it's quite an exceptional case, then you could try for the New England Journal of Medicine. But for example, we've submitted photographs to renal journals and gotten photographs accepted into the highest ranking renal journals. So it just depends on the specialty. Yeah, you just need to have a look and see whether they do accept photographs. Yeah.
There's another question. Is a case report or audit a must before advanced training?
No, it's not. But in terms of getting into advanced training, you want some things that are on your side, and you are going to have to do research probably as part of your advanced training, or at least a research report. And so you might as well get in early if you've got some time. And I think you have got a little bit of time now, and you've probably all had consultants who said, look, you could write this up as a case report. So it's worthwhile setting aside a weekend and doing it. As I said to start out with, a case report will never drop off the bottom of your CV. So it will always be there when you're going for a job, when you're going for a position the year after too, as a second year.
And Judy, there's another question that came through from your first presentation. Apart from Tally and O'Connor, are there any other resources?
Yes, and I was asked that question before a bit. Look, Tally and O'Connor has a lot going for it. I just don't know what the latest textbooks are. And I'm sure your registrars from the previous year would have a lot more information about them. But there's lots of different books. You have to be a little bit careful. If they're international, they may not follow the format that we use. They may not have the detail we use. And that's why I said construct your own template for a long case, and your examinations, your short case examinations, it's your medical student notes too will be good. But in terms of thinking what short cases would you get and what kinds of questions would you get, sometimes Tally and O'Connor have quite unusual clinical manifestations, and you're probably better off speaking to the advanced trainees in those areas rather than spending a lot of time on Tally and O'Connor. For example, I think Tally and O'Connor on polycystic kidney disease says you look for a conjunctival hemorrhage, which could be an extension from a subarachnoid hemorrhage. Well, I'm sorry, but you're never going to get that. You're much better off looking for hypertension and a mitral regurg murmur, looking for a fistula, etc. So make up your own lists of what you want to look at or look for, because some of the things in Tally and O'Connor, they're over-inclusive, but sometimes they're not what we would consider currently, that's all. But again, I've tried to emphasize throughout the morning that make up a list of likely short cases and what the clinical features are there, what the questions are, and I've already given you a list of the likely questions, and what extra features you should be looking for clinically.
Thanks, Judy. We're just about 5 minutes over time, and we've got 3 questions. Would you like to answer them?
That's okay. It's okay with me.
Yeah. At what stage of BPT do you recommend looking into case reports research?
You have an exam coming up. So you need to focus on that, but I've given you some ways to gently get into preparation for the exam that are really only going to take an hour or 2 hours each week at the moment. I would write, if you've got a case report, I would write them up now and get it published, get it out of the way, and then you can focus on the exam from now on. Case reports you can write up at any stage. I find the interns are often enthusiastic about writing up a case report, but it doesn't necessarily get done. And I find that the people who usually do write up the most case reports are advanced trainees. But it doesn't have to be that way.
How long can you expect the case report process to take in total, realistically?
Depends how much work you've done so far. And I would say that in a weekend, you would be less than a weekend. You could get a case report written. It may not be the standard required for publication, but maybe one weekend you write it, the next weekend you go back to it and you make some changes to it. And in that intervening week, you might talk to people and say, look, you know, they said this could be a result of the medication they're on, and just do a bit of research, but no, it's not due to the medication, and you get the proof for that. And then you change it the following weekend, look at the quality of the writing. Look, first of all, read some case reports in the journal you're thinking of submitting to, and have a look at the quality of them and how much detail they have. And write your case report very much following the format of those case reports you see in that journal. Do that, and then go back the following weekend, make some revisions, talk about it with your consultant before you start, show it to the consultant, and then potentially you could submit it. But as I said, BMJ case reports is good. Check with your library and see if they have a subscription.
And the last question, do we have to follow the exam techniques in order in Tally O'Connor? Having done other exams, some of us are better acquainted with British texts like McLeod.
McLeod, yeah. No, you don't have to use any particular formulation of the examination. You will be examined on whether you find the signs. So we see some unusual examination approaches, or different, I should say, and we think, well, maybe that person has learnt that technique somewhere else. As long as you get the signs, that's the important thing. That doesn't mean that if you're asked to examine the abdomen, you could examine the abdomen and not feel for a spleen or not feel for the kidneys. But there's a bit of flexibility in how you approach things. And that's quite acceptable. And it would be certainly acceptable to use another textbook. As I said, Tally and O'Connor have some unusual things they suggest. And if you do that too, you won't be penalised either if you get all of the answers right.
Thank you, Judy. No more questions, but I've also popped in the chat box if they have any questions who to contact. And this concludes our webinar this morning. So thank you to Judy and Jill again, and Nancy and Terence for also supporting this webinar. I hope you all have a lovely weekend and hope to see you again soon. Thank you so much.
Okay, great. Okay, and just one final thing. Thanks, Pavitra. That we may have some more long cases for you to look at. Anne Powell from the Victorian State Committee is just having a look at the long cases online and seeing if it needs to be any updates done. So that would be a long case, but of those special areas like bone marrow transplant, etc. Okay, thanks. Good. Thank you.
Thank you.
Thanks.